Good afternoon, and welcome to Establishing a Healthcare Data Quality Assurance Initiative, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by our managing editor and director of social media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today to submit your questions. You can type them in at any time in the bottom right-hand corner of the screen and leave the default set to all panelists. Send them in as they occur to you, and we'll take them later in the program. And you can use the URL on your screen. It's been sent out in the chat box, and it's at the bottom of some of our slides in order to download the deck. Just so you see how we're going to spend our time today, first we're going to go about 30 to 35 minutes with Omid Shabestari, Dr. Omid Shabestari, Director of Health Analytics with the Carilion Clinic, and then we're going to have our Q&A. So without any further delay, I am going to turn it over to Dr. Shabestari. Dr. Shabestari, thanks for joining us today.
Thank you very much, Anthony. Good afternoon, everyone, for the people on the East Coast, and good morning to our participants from the West Coast. Just a little bit introduction about our organization that I think will help to scope what we've achieved, and if you want to translate this as comparables to your healthcare settings. We are a healthcare organization of 7 hospitals and around 240 healthcare practices across the southern region of Virginia. Some of the things that comes very important as part of the conversation is that we are a single EMR system. So for some of you guys who might have been using different EMR solutions in different hospitals, you may have a little bit more challenges, and I will go through those. And also we have a single repository that all our healthcare hospitals and practices connect to. So we've been blessed by having this single point of reference and single point of access to information. For some of the healthcare organizations that may have more than these, considering the EMR systems or multiple repositories based on the fact that we know many healthcare organizations are spread across the country, you may have a little bit more work to do to get here. What I'm going to cover today is some of the prerequisites that we need to have in place to have a successful exercise of data quality. And I will tell you how we achieve these goals. I've been blessed by a number of good members of my team that have been successfully contributing to these activities, and I will name them at the end. That helps you for some of the healthcare systems that might be at the starting point of setting these type of systems to know what it takes and what preliminary steps you need to have in place for successful data quality assurance. But then at the same time, there might be some of the other healthcare organizations who might be at the same pace and level as we are, and we may have some interesting lessons learned to share with them, and even some of the other healthcare organizations that might be far ahead of us, and we would love to hear from them as part of the QA conversation. I'm sure there would be very interesting lessons from them for the whole audience as well. So what we're going to cover today as part of our objectives is we will say and discuss about some of the structural needs with regard to the data governance that needs to be in place to host these data quality initiatives. We will talk about who needs to help for a successful delivery of these solutions and how we establish that. And also, we'll talk about how we can look into our data quality initiatives and see whether they have been successful or not. So generally speaking, when you talk about data quality, the first thing that comes into mind is research. One thing that I should emphasize here is research is not just purely academic research. As you may have in your organizations, there's a lot of process improvement and QA/QI type researches that will benefit from good quality data as well. But that's mostly where most of the conversations start. It's not going to end there. As we will discuss, you will see that this affects every piece of information sharing that happens in the organization. So one thing that drives the quality of data and improving that is to making sure that you will receive a consistent and coherent information across the organization. In many healthcare systems, you may have pockets and silos of excellence of producing different type of information. And it's not a very uncommon scenario that you go to a meeting and you see different people talking about the same measure but with different numbers. That could be because they are looking at it in a different way, they are looking at different sources of information, or there's not much confidence about the quality of the data just because of all the incompleteness of the data that may exist in a healthcare system. This is one of the things that mostly as part of my university courses I talk with my students. The fact of the matter is that the quality of data in healthcare setting is not among the best ones when you look across different business lines. And the reason being is when you talk about the quality of data, in many instances, it's been compared to some of the other industries, for example, the retail and also banking. The truth that needs to be considered is that the data is the result of the process in those industries. When you do any transactions for money transfer, it automatically generates the data. When you do any kind of shopping, at the point of sale services, you generate data. Whereas in the healthcare system, you can actually provide all the services, but with limited documentation of information. We are aware of a lot of opportunities that is in place for improving the data with meaningful use and other initiatives that started either in US or other countries, but it doesn't block the process. So you may have many situations that the data is not either documented at all or is documented after the fact just because you hear from healthcare providers that they've been dealing with some urgent cases and the most important thing is the life of the patients and all those things, and the data is not captured or is captured but is not cross-connected across the system. So very much it depends on the direction of the organization. We hear from many healthcare systems that they want to be data-driven. They want to be information-focused. That support from high level is one of the main things that helps with success of exercise of this. The other thing is with regard to the effectiveness. It's not unlikely that you see some healthcare organizations that their life is business as usual and there's not much competition for improvement, especially when you hear some of the limitations that is being posed more and more on controlling the expenditure, reducing the cost of care. You hear from many people that the cost of care in US is much higher than other countries in the world. Those conversations boost the initiatives around effectiveness. And those are the kind of things that we can leverage to focus on improving our data. Because if you want to show that you are effective, you need to have good data, you need to have better results, better quality of information to be able to claim your success. So we talked about the issues about healthcare organization and the data being an after fact. In many healthcare systems, especially when you look at a little bit further in the past, there have been many sources of data. With the introduction of EMR solutions as comprehensive as we see them today, that becomes less and less issue. But the fact is, that is mostly the clinical side of it. Some of the EMR systems are capable of hosting other pieces of information, for example, about the cost, about the material management, but not every system does that. And when it comes to effectiveness, those are the kind of things that are taken into consideration. In addition, you hear nowadays a lot more evidences about successful delivery of healthcare system with regard to the measures of quality, with regard to the measures of patient experience and patient satisfaction, and you need to have them connected to each other, at least if not in the same place. The other thing is the capabilities of processing this data, because many of you who are in the responsibilities with handling the data, you will hear that the data in the healthcare system is vast by itself, and now we are talking about sensor-provided data, we are talking about genomic data, and many other ones that increase the scope of information which is available to us. So one of the limitations was how we can handle processing these. The solution that we came up with was pre-aggregating the data. So we leverage some of the technologies of OLAP and pre-aggregating the information in an analytical cube, and we use that as a source for looking into data quality. As I will explain to you later, one of the limitations is that you want to continuously parse this information. You don't want to do this on an ad hoc basis, otherwise you will lose track of that. And to be able to do that, you need a lot of this information be readily digested and available to you. Quality of the data can be affected by many different things. It can be as form of missing values, typos, incomplete information, incompatible information, and many other items. And also, these issues with the quality of the data affects any kind of reliability of the analytics that you will do. There's an old saying, many people, especially the traditional type researchers, believe that if you want to have a good research, you have to collect the data for it yourself. Well, there's a trade-off, yes. That gives you a very high reliability, but what about with this huge amount of data that we have available? What do you want to do with them? You just want to ignore them? Or if there's any way to consider usage of the data with a level of confidence that you can have in that data and how you can improve that. So there's a good selling point for improving the quality of information. So the structure that we put in place, the framework around our data quality, first was our data governance. Many of the organizations may have the similar type of a structure. It's very much dependent on how much active they are. Last year when we were discussing with some of the other colleagues at the core conference of our EMR system, many of the healthcare systems had this structure in place, but the meetings was not as frequent as they were expecting, and the production was not very successful. When we presented our work and we shared that we have around 1,400 terms and definitions approved in our data governance, that was a wow moment for many of the other healthcare systems. And maybe one of the reasons was they were trying to get the acceptance and buy-in from everyone and anyone on any of the terms. Whereas we came up with a group of excellence that were helping to craft this and put it in front of organization and just ask if they have any argument against it. And if not, we gave them a certain time, depending on the workload, a week or two, and then we took things as granted. So that helped us define very well what are we measuring our data quality. The terms, the measurements, their definitions, all there were built. The Data Governance Council is mostly overseeing and approving. You would need a lever under that, which we call them Data Stewardship Committee. And these are the people who essentially live day in and day out with data across the organization at different levels. They help us craft all the definitions for us. And then also we identified the responsibilities for each of those elements that I will explain further in the next slides. So we formalized our Data Governance Council and Stewardship Committee. We got them to help us create the definitions. We put them in front of data governance, get the approvals for those, not only for the terms to be used, but also for the terms to be retired. Because as you know, there is always new definitions and new criteria being introduced by CMS or other governing bodies, and you want to make sure that you are on top of those. So here's an example of the data governance structure and the tool that we are using. There are several tools in the market that you can leverage any of them. They might have a little bit less or more of functionalities, but that's what we do here. For example, you see that we define a term. This is the procedure level for our surgical cases. We define the type of it. At this stage, this was a proposed term which needed to go through the approval for data stewardship and data governance, and we define how they are measured. Also, one thing that we leveraged, which was a very useful and successful exercise, was this list of valid values that you see at the bottom. One of the limitations is many of the traditional data governance tools are limited in creating dynamic content, so we cross-connected that with our analytic platform to get the list of valid values, because this drives a lot the conversation about the content of information that you have in your organization. Many of the concerns about the quality of data is because people do not have enough exposure to know what is in the system. In many cases, they may have some form of tunneled vision just to the reports that they are receiving. Opening list, high-level, bird's-eye view was something that we found very useful in the conversations, both around data governance and data quality. So the next item that I would love to share with you is the process that we followed for the data quality assurance. Not only we defined the terms, but we started with limited number of items that we focus on the quality of the data. These were mostly the items that we already had centralized in our enterprise data warehouse. We had some form of agreement with regard to what is the source of truth for those, if there's multiple, and how we compare them if there's a disagreement between that. And we built some front-end interfaces that we made available across the whole organization. We didn't want to have any kind of limitation. The strategy was full transparency, and we created some tools which are based on web-based interfaces that can easily be accessed from any computer in the organization. And we made it available across the board so that people can see and get some sort of understanding of how good the data is. That by itself helped us drive a lot of conversation about what is the confidence interval in any of the measurements that we provide off of those data, and then what would be the strategy around taking actions for those. For this, obviously, we needed to have several levels. So we used the RACI model, identify who's going to be responsible for ensuring that that data is to the best of quality as possible, who would be accountable, which will set the oversight and the strategies and targets for improving those data elements, who needs to be consulted, which is mostly the consumers of the information at a little bit higher level, and then inform, which are the pure consumers of the data. So we set these up, and we continuously exercised based on different measures that we had in place. I wouldn't say that this is a final stage as we are, because continuously we take new solutions, new software system. They have the new sets of data that they bring in, and also we continuously introduce some of the measures of data which is publicly available, like census data. So this is going to be an ongoing exercise. The reason that I'm emphasizing on this is that you don't want to set up a plan which is for a temporary basis. The big picture should be a continuous exercise, but for each of the subsets of information, you would have different groups of people coming in and going out. They come in when a new source of data is identified. They help with the contribution of how we're going to measure it, how we're going to assess the quality of the data. And then they may be a little bit disconnected, but you continuously keep contact with them to show them the result of their work. That brings a lot of interest and support for your project. The main point with this is I've heard from many organizations that they are hoping to see much more people attending their meetings and exercises in this context. You need to be aware that this is going to be an on-off situation. So it's not the case that you would expect everybody needs to be involved with every piece of data. People just have interest around the things which is relevant to their work. So don't be dissatisfied if you don't see a huge turn up on this kind of exercises. So this is one example. Here you see our quality dashboards for surgical cases, whether the class of the surgery is defined, the patient class is defined, the type of anesthesia is defined, primary service, and also the level of procedures. And as you can see, for each of these, we have some measures that shows where we are against our target. We try to use a traffic light model, which is easily interpretable and consistent. And we have, similar to this, many, many dashboards for different type of data that we have. You see one item on the right side, which is available patients. This was an arbitrary definition that we came up with, but it helped us very much with regard to improving the quality of data. Our definition of available patient is a patient who had any sort of encounter with us in the past 3 years, any completed encounter. And the reason being, and you will see this in many healthcare organizations, is there's a considerable proportion of records in your system which are just purely from traveler patients, and they are not consistently in touch and registered with your services. Normally, the improvement of quality of the data pertaining to those patients are not very easy because you don't have a continuous model of contact with them. So we define this and we put a slicer here, a drop-down menu, to switch between available and non-available patients. And most of our initiatives are based on the patients who are available. If you had any experience of working with the data in your system, I'm sure you've seen that there's a considerable number of patients who are at a very high level of age, which is impossible just because you didn't have any contacts with them to identify that these patients are passed away and clean up from your system. So that's one single example, but there's many of these that you can take into consideration. So some of the challenges. Spreading the message, making sure that the organization realizes how much they may be affected by the quality of data, because most of the measures and reports that you see in the organization are point measures, like averages, medians, modes, and as such, which doesn't bring that exposure of the pitfalls in the data. Buying from all areas of organization, this is something that you aim for, but you don't need it to start your data quality initiatives. You don't want everyone's blessing. It builds up. Obtaining the resources, we leverage our analytic queue very much because as you saw those dashboards, reprocessing them on a daily basis is almost impossible if you want to do it from every piece of data that you have. Having a good business glossary program is very important. The reason being is you don't want to work in silo. You want to continuously present to people how much progress you are making, how much improvement you are making, and how much opportunities for improvement you identify. It helps very much. So for every type of dashboard that we are creating in Carilion, we have the link to our business glossary program built into them, and specifically to the term and definition related to those dashboards. So we make it as much available to people. We have several publications in our regular publications across the organization, which we call them ePulse. And we had a lot of online and offline training courses made available to people. so that they can learn it by their own pace and their own time. Reporting tool, as you saw, some of the interfaces is very important because you may be able to produce many of these reports as part of email correspondences, but they easily get lost in the weed. You want to have somewhere that people can go to and see everything and anything that you are producing for them. And also training. As I mentioned, we had e-training, we had in-person training, and also some published documents about what we do and how we do those. The whole initiative is around being transparent and letting everybody know what we do, why we do, and what we are trying to achieve. Some of the conclusions, it defined and redefined some of the roles and responsibilities that we had. The original traditional system that was designed in this organization could not handle this amount of effort. So we had to identify and repurpose some of our activities to make sure that we have the right people at the right time and right place to achieve our targets. We created our organization business glossary. I really emphasize, if you haven't engaged in doing that, do it as soon as possible. It's one of those things that at the beginning there's not much sparkle around it, but as you step into some of the pain points of the organization with regard to discrepancies of definitions and results, you will see that how easily and fast it will pay off. Identify the sources of information. The number of sources that we identified after we did an analysis and a survey across the organization was beyond my belief. There's too many of those. Try to identify them as early as possible and have a program in place to start carving through each of them one at a time. Try to incorporate them in somewhere that you can tap into it directly. If you don't have an enterprise data warehouse or analytics cube, I would strongly advise to do that. The problem is when you are working with many of the vendors that are providers of individual solutions, they say their piece of work is everything you need. That's definitely something you need, but not everything. You need to be able to piece together all these sources of information. I'm sure that in many of your settings you have extended amount of Excel files, Access files all over the place. Trying and putting an effort to consolidate them definitely pays off. That's one of the building blocks for being successful with your data quality. Data completeness is always an issue. It's just a matter of having a strategy of how to handle it and how to react to it. Creating KPIs, cross-validating the data, processes for improving your data and not just leaving them in silos, and the RACI models definitely are going to help very much. So few recommendations also. Acknowledge the impacts of the data, establish the data quality assurance initiatives across the organization. Don't wait for others to do this for you. Many of the external vendors have their knowledge and experience at the level of organization systems that they've worked in. Each of our organization is unique in its own sense that for doing this kind of big picture initiative, you will benefit from their collaboration, but they cannot do the whole work for you. Expect the variations, expect the differences in source of truth, make sure that you continuously deliver whatever is the product of these initiatives. Work on an agile process, something that can continuously hit back to the consumers of your solutions and provide them with something useful. Define the RACIs. You would have two bottlenecks here, the points and the nodes that there is multiple stakeholders on them, getting them to work together, and the points and nodes of information that nobody is taking responsibility for them. Those are the two main points that as part of RACI model you should resolve and work toward improving. Have regular meetings with them, with your councils and committees, but not too regular. Normally the way it starts at the beginning, you may have a little bit more frequency, but as soon as you build the momentum, start to reducing the workload of the meetings. You want to do more production rather than talking. So that is very helpful. And also, it's not going to be, as mentioned here, once and done process and solution. This is going to be a work of a lifetime for any healthcare organization. It becomes easier and easier. So before I end, I would love to acknowledge a few of the members of my team who've been significantly helping with this process, and they help us also presenting some of these content in the HIMSS conference. Dr. Tanya Locklear, who's a PhD in statistics, helped us very much with the work of producing our KPIs. Mrs. Shea Jesse, an excellent computer engineer, helped us with creating our data cube, and also Ms. Courtney Esposito, who was an excellent member of my team, and she is still a good member. She helped us very much with production of many of these reports that we made available across the organization. This is a completely team effort, and you really need to have wonderful people around you to be successful with this. So with that, I will pass the control back to Anthony, and we would love to hear from any suggestions, questions, or answers.
Excellent. Well, thank you, Dr. Shabestari. That was a great presentation, and we're looking forward to some nice Q&A. So as I mentioned, please type your questions into the Q&A box. Leave the default set to all panelists. First question, what roles and departments of your organization are represented on the Data Governance Council?
That's a wonderful question. So you want to have the major players, essentially whoever is working with the data. We try to incorporate as much of the business lines, including clinical, non-clinical, finance, operations. It very much plays into how busy your organization setting is. Sometimes you want to have some people who are significant contributors, but they don't have time to continuously interact with you. My strongest suggestion is try to work with them offline and be a very good communicator. So on a frequent basis, we just send a notice, a kind of burst notice to everyone that what we've done and what suggestions have been made. But one thing which is very important is how you start the scope of the work. If you're starting at the beginning with the clinical side, then you want to have those people around the table. If you are starting both at the clinical and non-clinical, then you want to make sure that whatever initiative you are working on, you have the accountables, as we talked about the RACI, connected.
All right, very good. Next question, do you need to work with the marketing department on communicating this project around the health system?
Absolutely, and we had very good success with that. They helped us very much with crafting the message that is going out, and also with our e-learning solutions. Don't underestimate that. In the healthcare setting, everyone is so busy that you want to let them to follow with you in their own pace and at their own free time.
All right, very good. How do you get people to understand the importance of entering good data?
So one thing, that's a great question. One thing is you want to show the overall picture of how good the data is and how it may affect, if it's not good, the information that you provide. One of the exercises that we did based on the confidence interval of the data that we had, we produced some information that was showing people how much the information that they are receiving can vary. And that was a big wow moment to show them this is what you see, but in reality it could be this value. That's the public message. The next step, you want to hone specifically to the points where the problems are rising, and that's where your data cubes can come into play, because you can easily explore your data and find out where is the point of problem. In many cases, because of some very reasonable issues, you may have some problems in certain areas. Maybe some of the devices that they use to capture the information is not working as expected. You need to be on top of those and try to work with those specific ones to improve the data. If you want to just take a shotgun approach, it might not go across as much as needed.
Very good. Can you make data entry easier for doctors and nurses? What are your thoughts on the role of scribes?
I think it's a wonderful point. You know, being on the both sides of the table as a physician and as an informatician, there's always a conversation, a very true fact, essentially, that the work of physicians and also some of the other providers, nurses, and other people are so much optimized in the way it is that when you try to introduce a third leg there as a tool and as a digital capture of information, in many cases it slows down. There's many people who really rely on their side people to capture the information for them. The good thing, the good fact is we are moving faster and faster toward environment-based sensors that can collect information for us. So you would expect that you see more data coming in. The other thing is how you set up your best practices and your workflows in your EMR system. If it enforces them to capture the critical points of information, they wouldn't have a way around, and they have to document it for you.
All right, very good. How do you deal with it when different departments or constituencies they've defined data in different ways, and they each want their way to be the one that's universally adopted, but the health system has to select a particular way and standardize on it? How do you handle those conflicting points of view?
Okay. The message I'm hearing from this question is a real-world pain, and this is something that we've seen very consistently. To some degree, you can enforce consistency, but then people have their own way of doing things. There has to be some steps in place to synchronize those at the data repository level. A very famous example of this is coding information, mainly on the diagnosis codes in ICD that people tend to do things in their own way. That will not go away, to be honest with you. And you need to have a translation process that, to the extent possible, can morph all of these to a consistent shape.
All right, very good. How do you make sure that progress you've made in this area doesn't erode, that you don't sort of backslide, maybe perhaps by not being vigilant or not sort of making sure that things are, you know, sort of etched in stone?
That's a very good point as well. The fact of the matter is this is a continuous improvement exercise. Nothing is going to be perfect at the beginning. It's just a matter of continuously working and optimizing the processes and measurements that you have. When we are talking about KPIs, in many instances, you may set some unrealistic goals at the beginning just because we are very hopeful and excited. But as long as you are on top of the game and continuously monitoring and improving it, it's going to move and morph to the right direction.
All right, very good. I think this will be our last question. If you could pretend you're a consultant for a moment and you're going in and looking at other healthcare organizations and their data quality initiatives, is there something you would see or could see that would tell you that the organization was not set up for success? Anything come to mind that would be sort of a red flag either in the way you've set up or carrying out your data governance plans?
So what I would say the first starting point is each of the organizations, at least to some degree, have some organization goals and targets, whether it's improving patient experience, increasing revenue, reducing qualities and errors. Just simply honing to see whether any of those measures have quality issues and to what extent they may be affected by not having a consistent and coherent information in place. I think that says from a consultancy perspective, what are the opportunities, and from organization perspective as a buying point for starting some of these activities.
Excellent. Well, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could answer that, we'd appreciate it. Regarding continuing education, those of you who hold the CHIME CHCIO certification program get 1 CEU for attending our events. So let CHIME know you are here, and if you've asked us to do so, we will. You'll receive an email when an archive recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of events. So with that, I want to very much thank our speaker, Dr. Omid Shabestari, and I want to thank you, our attendees, for always coming to our events. With that, everybody have a wonderful day. Thank you.
Thank you, Anthony.